We have some powerful immunotherapies and they're being talked about right here at the conference. But there were recent results in the study that you very much participated in looking at a combination of anti-CTLA-4 therapies and anti-PD-1. Tell me first of all about the basic findings of that study that were announced recently.
So I think it's already a large progress that we now have PD-1 antibodies available, and only with this type of immunotherapy we already reach response rates of 40 to 50% with objective tumor remissions just by an immunotherapy. And now this is even topped by the combination of PD-1 and CTLA-4 antibodies. And with the combination, we reach around 60% of objective tumor remissions just by the immunotherapy. And with this result, the combination is clearly superior either to CTLA-4 antibody alone or also to PD-1 antibody alone, but it is more toxic.
Right. Now, what then is the case for using single agent right now? Because great progress was made simply with single agents, wasn't it?
Yeah, so I would say we have to define criteria. And so there are predictive markers like low tumor volume, lack of enlargement of tumor markers in the peripheral blood, and a good immune system with high relative values of lymphocytes and eosinophils. And if we have such patients, it's very likely that they will respond to PD-1 antibodies alone with a relatively low toxicity. So probably we will be able in future to define and to select which patients should get the single substance, and in patients with higher tumor volume and with more progressive disease, more advanced disease, we probably will start with the combination.
So is anti-PD-1 therapy eclipsing the anti-CTLA-4 right now?
Yes. So I think anti-CTLA-4 will in future have only a role in the combination and not as a single agent and not in first line.
Now, there is also, of course, a possibility of adding to all of this targeted therapies. How do you see those as coming into the pattern of treatment?
We will develop a number of additional substances, TIM3, LAG3 antibodies, but presently we do not have much information. So we will learn what is their toxicity and what is their efficacy, and then probably such substances will either be combined to the already existing ones, or they will substitute, for instance, substances like ipilimumab.
What should doctors be doing for those patients who don't respond well to the checkpoint inhibitors, whether single therapy or combinations?
I think for those who don't respond well, we assume that they do not have the anti-tumor response, the specific sensitization against tumor antigens. And on a long run, we have to develop specific T-cell therapies for these patients. Presently, we have to give chemotherapy, or on those who have the BRAF mutation, we give kinase inhibitors.
Now, we're getting big extensions of life. Are we seeing the plateaus that were being talked about initially with checkpoint inhibition?
Yes, so let's say we know that the plateau for ipilimumab is around 20% long-term survivors. We presently do not know what will be the plateau for PD-1 antibodies because the follow-up time is too short to already define a plateau. We hope that it will be, let's say, 30, 40, 50%. But we have no data.
So for the practical doctor in day-to-day clinical practice, what is your summary of what the approach ideally should be to individualized therapy for his or her patient?
I would say nearly all of our metastatic melanoma patients should receive a checkpoint blockade therapy. And for all those who carry the BRAF mutations, an alternative remains the BRAF/MEK inhibition targeted therapy.
And coming down the road, do you see ways that this will be improved significantly? It seems it's made such progress already, it might be rather difficult to improve on that.
There's still, let's say, a majority of our patients dying from metastatic melanoma. And so also some of those who initially respond to the immune therapy, they may progress later. Yeah? And so nevertheless, I think we have to further improve our immunotherapies with specific T-cell targets.